This is Doctor Patient, a podcast that examines all the aspects of the patient-provider relationship. I'm your host, Heather Johnston, MD, a real-life doctor and patient. Hi, listeners. Thanks for joining me today for the start of an in-depth look at drug costs in the U.S. This topic is vast, which even that is actually an understatement. This topic is vast and complex and convoluted. In this episode, part 1 of 2, I'm going to review the history behind the rise of drug manufacturing companies here in the U.S., the creation of other entities that act as middlemen between them and you, and how all this laid the foundations for how drug costs are determined today. Next week, I'll release part 2 in the series, where I'll dive into what you can do about the cost of drugs at the register, whether you're uninsured, insured privately, or insured through Medicare and Medicaid. So I'm assuming that all of you listening have heard of Ozempic and or Mounjaro, the drugs created for type 2 diabetes that also happen to help you lose a lot of weight. They are the hot drugs all over the world right now for both of those reasons, though probably more the latter, let's be honest. Whether you can get them and actually afford them depends on what country you live in, what your insurance status is, and more. For example, here in the US, Ozempic retails for like $1,000 a month. In Japan, which is the second highest cost in the world for this drug, it goes for only $169 a month. 93 in the UK, 83 in Australia, 87 in Australia, and 83 in France. Huge discrepancy, right? So what the heck is going on? This is just one of a million examples, actually. On a much less shocking scale, I went to Walgreens a few weeks ago to pick up a prescription, and it cost me $30 for a 1-month supply. I pulled up the app called GoodRx, which compares the cost of medications at different pharmacies, and saw that the same medication cost $38 at one grocery store, $44 at Costco, and $140 at a couple of other pharmacies. So again, what's going on? Well, my friends, today we're going to talk about drug costs in the U.S., just the U.S., how we got here, how the system works, what the problems are with it, and then next week, some things you can do about it. This seems like a good time to say that if you're not driving and have a pen and paper handy, you might want to grab some. This is some ridiculously complex stuff that we're about to dive into. I'll also be posting a lot of links and resources in the show notes, including a very handy, if not very convoluted diagram I borrowed from a source explaining most of what I'm saying today. Let's begin with where things started with drug making. I promise that the history of rise of drug companies is relevant to cost setting of drugs today. I was listening the other day to this really interesting episode of a podcast called Acquired. It was an episode from back in January that covered the Danish drug manufacturer Novo Nordisk, the pharma company behind Ozempic. They went into some history of the company, but what really caught my ear was when they described how insulin was first developed in the 1920s at the University of Toronto Medical School by some of the folks that later actually go on to create Novo Nordisk. It was such a huge game changer. I mean, at that time, diabetes was pretty much a death sentence. The doctor scientists there knew that they needed to contract with someone to make more of it, but they were hesitating because at that time in history, it was considered pretty unethical to try to make money off the development of health and life-saving medications. I mean, can you imagine that mentality? That people were horrified by the concept of medicine being a business? If I had some canned audience laughter, I'd insert it right here. So it's like the 1920s. The University of Toronto has like 24 vials of newly made insulin, but there are probably over 2 million people in the US alone with diabetes at that time. So they really do need some help to make more. So the University of Toronto, which has a teeny tiny lab and knows it will not be able to handle the demand it's anticipating for the insulin, gives a limited 1-year exclusive license to produce and develop insulin to the U.S. drug maker of quinine and other successful drugs at the time, Eli Lilly. Then between the 20s and 70s, the healthcare industry grows, but it remains pretty fragmented. All areas of it are growing at the same time, but in parallel. You had small insurance companies, independent pharmacies, doctors' offices, hospitals, drug manufacturers, all growing in parallel to each other. Then, a few big things happened that really shaped the next 50 years of the U.S. healthcare and drug system. First, pharmacy benefit managers, or PBMs from here on out, come on the scene in the 60s as middlemen. More on those in a bit. Second, major software developing change the way that growing insurance companies and PBMs manage all that incoming patient data. And third, the discovery of bioengineering of drugs help skyrocket production and thus availability of manufactured drugs. Remember, because the industry is super fragmented at this time, you have all these little tiny companies trying to negotiate individually with each other. Like this insurance company contacts those 7 pharmacies, that pharmacy contacts these 3 health insurance companies. It was crazy and inefficient. So enter PBMs. These were a new kind of company founded by pharmacists, interestingly, that originally dealt with reimbursing pharmacies for drug costs. They're even credited with the development of the idea of a drug formulary, which is a list of approved drugs that someone can choose from. But with the rise of availability of prescription drugs, management software, and even more and more employer based health insurance, PBMs grow fast. And they quickly pivot more towards helping the health insurance companies manage not only their drug formularies, but also their drug and other medical claims. And they become a go between for drug manufacturers and health insurance companies. Suffice it to say that these kinds of companies grew in popularity over the 70s, 80s, and 90s, and have become a major player and influencer in the US for drug costs overall. Today, PBMs manage prescriptions for the roughly 220 million insured folks per year in the US. They cover like 2 billion prescriptions per year, about 70% of all prescription orders in the US dispensed for outpatients. But also, they've literally changed the way the drugs make their way from the manufacturer to you. So let's talk about how it all works today. This is the part where I was thinking some paper and pen might be handy. Or maybe pause and click the link in the show notes titled Convoluted Diagram of US Drug Costs and follow along. What you'll hear is that there are just too many players in the system now, and that drives up cost for the end user, patients, because each player involved wants a piece of the pie, so to speak. I'm told by a friend who works for a major drug manufacturing company that if they could sell direct to the patient, costs would probably be about 80% less than they are now, if not more. Don't get excited, because that's almost certainly never going to happen, at least not in our lifetimes. So how does that drug get from the factory to you? It still all starts with the manufacturer. That's the company that literally makes the drug. The only people they sell the drugs to, though, are wholesalers, companies that buy from the manufacturer at a cheaper cost and then resell it, which is called distributing, to a pharmacy. Then the patient, you, goes to the pharmacy and gets the drug. What we just went over is called the flow of drugs. This part isn't too complex. It's a lot like any retail industry: maker to wholesaler to retail to consumer. Okay, deep breath. Now we're going to talk about the flow of money, and this is where it gets super complicated. But before we dive in, I need to come back to the idea of the drug formulary. If you have health insurance, your insurance company has a list of approved drugs that they'll cover most of the cost for if your doctor prescribes that drug. If your doctor prescribes a drug not on the formulary, they will not cover the cost and you will have to pay the full retail value, which can really add up. So the flow of money. There's no clear start and end here as there is with the flow of product. On that convoluted diagram I mentioned, there are money arrows going in every single direction between all the players. So we can really just pick anywhere to start. And I'm going to start with a concrete example that tracks the money. A PBM, pharmacy benefit manager, will go to a drug maker, let's say Eli Lilly, and say, "Hey, I represent health insurance company X, and we have 2 million insured members. If you give me a good deal on this new drug Mounjaro," remember that's the competitor of Ozempic, "I'll make sure it's on the formulary for health insurance company X that I represent so that all those 2 million members can get it if they need it. But if you want me to do that, you have to give me a humongous rebate." All right, note that I did not say discount, I said rebate. More on that shortly. Eli Lilly is thinking, well, that's a lot of potential patients to get this drug to, so we really want this to happen. Whether it's because of their good intentions of getting an important life-saving drug in front of so many people that potentially need it, or because of their worse intentions of knowing that that's a lot of drug to sell and make money from, they're motivated to do it. So they say, okay, we'll give you your humongous rebate. And I'm using fictional but realistic numbers for this next part of my story. But let's say Eli Lilly thinks, well, it costs us $100 to make one month worth of Mounjaro injections in our factory. And the PBM is demanding a 75% rebate off our retail cost, which, by the way, is a pretty common rebate amount for a super hot drug. So we'll start at the base cost of $100 to make the one injection and add on a ton of money to cover the rebate that the PBM wants. But that's not all. We also want to keep paying our electric bill and pay our employees. And also, we want to try to recoup the $10 billion we put into creating this drug over the last 10 years or 20 years of research and development. That's a realistic number, by the way. And don't forget about the other 9 out of 10 drugs that we developed that never made it to market, but that we also invested hundreds of millions of dollars in. We need to recoup those costs as well. So we're going to set the retail value of that drug that costs $100 to make at about $1,000. In this model, starting at $1,000, the PBM takes their demanded humongous rebate of 75%, or $750. Eli Lilly then recoups their $100 for the making of the actual drug, and they're left with $150 of profit that goes toward all the other costs I just mentioned. When you hear it this way, you might react the way that I did, which is, I can't really blame the drug manufacturer for wanting to recoup their research and development and other costs. And I can't blame them for feeling like they have to negotiate with the PBM. My friend who works in this industry says that if they said no to the PBM would just go to a different company and get a different brand drug, and then they'd be screwed and potentially go out of business. When I asked if the drug manufacturer could just sell direct to patients, he laughed for a super long time and then said the same thing would happen. PBMs would be in an uproar, they'd stop doing business with them, and they'd lose so many billions of dollars from lost potential revenue that, again, they'd likely go out of business. Now, let's go back to said convoluted diagram and trace the money in a couple different directions to make sure we really get it. This time we're going to start with the health insurance company. They take money in, both from their millions of insured members in the form of premiums that you and your employer pay every month, but they also take money in from the PBMs who give them a share of that rebate that they got from the drug manufacturer. And now they have all this money. Where does it go? As far as I can tell, the only money going out of health insurance companies for drug costs specifically seems to be back to the PBMs to pay them for their negotiating services, and I think they keep the rest for themselves. It's not completely transparent. Now let's follow the money a different way. We're going to start with you. If you're insured, you pay out of pocket in 2 directions in general for medications. First, you pay towards the health insurance company in the form of your premium. The second way you're paying is the opposite of the flow of product that we talked about earlier. Remember that drug flow is drug maker to wholesaler to pharmacy to consumer. Well, the money you pay at the register goes in the opposite direction of that. You pay to the pharmacy, who pays to the wholesaler, who pays back to the drug maker. There is one potential way you might actually take some money in the form of a discount, but I'm going to leave that for next week's episode. Lastly, let's follow the flow of money in and out from the pharmacy benefit manager's perspective. As I've said before, they're receiving a rebate from the drug maker that reflects that negotiated rebate. They also take money in from the health insurance company, as just mentioned. They pay out both to the health plan, which is a part of the rebate that they're passing on to them, and also to the pharmacy, who they separately negotiate with for how much they'll reimburse. And also to the pharmacy, who they separately negotiate with for how much they'll reimburse them for what you picked up and paid for. This part is murky because there's not a lot of transparency about how much PBMs reimburse pharmacies. That's all sort of hush-hush. So now we've talked about which direction the money flows in, how the drugs flow, but how is your actual cost determined when you go to pick up a prescription at your local pharmacy? Remember my earlier example of the drug I picked up at Walgreens costing a different amount at every other pharmacy? Well, behind the scenes, your cost is determined by the PBM that your health insurance company has contracted with, since they are ultimately the ones negotiating which drugs will be on your formulary and what their cost will be to you. Or looking at it a different way, your cost is determined by what health insurance company you have, whether the drug is on formulary with that health insurance company, and what your copay is. The copay is part of the contract you entered into with the health insurance company. Like if you've ever looked at an overall table of what your health plan benefits are, it's listed there. For example, there's a line item that says what your likely deductible is. And then there's a line that says what percentage of your inpatient and outpatient visits they'll cover. Or there might be a copay for seeing some specialists. And one of the line items there is what your copay is at the pharmacy. Pretty typical is 25% of the drug cost. But guess what? That's based on the full retail value of the drug, not on the net cost of the drug to the health insurance company. Remember that they probably got that drug at a 75% discount, but you still have to pay your copay based on the full retail cost. Most of the time, this probably just doesn't feel like a big deal because most drugs that we pick up at the pharmacy are not that expensive. As an example, most of stuff I pick up costs me anywhere from $0 to $30 a month, which is thankfully doable for me. But if I want to go get Ozempic tomorrow, my health insurance company will make me pay that same 25% copay based on the retail value of $1,029 a month. So I'd have to pay $257.25 per month for it, which is a ton of money. And this is probably one of the two numbers you're hearing a lot in the press lately. The $1,000 number is the full retail cost, but most people don't end up paying that. But a lot of people are talking about paying $150, $250, $350, $450 per month for it. And that's all really probably based on their copay or other discounts that I'll get into next week. So another person with a different health insurance company or even a different plan with the same insurance company as me might have a different copay. It could be more or less. Lastly, before we move on from actual retail costs at the register, a quick note about branding. Did you know that Novo Nordisk's Ozempic and Wegovy are the same drug? That Eli Lilly's Mounjaro and Zepbound are the same drug? Well, they are. Same drug with different brand names for different uses. Ozempic and Mounjaro are marketed for diabetes, and Wegovy and Zepbound are marketed for weight loss. And guess what? The weight loss ones are more expensive. The current retail cost of 1 month of Ozempic is $1,029, as I said. The current retail cost of Wegovy, the same exact medication and dosage, is $1,349. Because this is the United States of America, and we have a free market, and corporations are king and can set whatever pricing they want to meet demand. Right? Not exactly. There's been some pushback from the federal government in the form of setting cost caps on certain drugs, though that isn't happening yet for these new ones, though their cost has made headlines every week. For the time being, PBMs have us all by the balls. In the early days of PBMs, there were actually hundreds of them. That's dwindled down to like 30, but really there are 3 big ones that cover about 80% of drug sales to insured people in the US. And in all this consolidating and huge growth, it's become almost impossible for drug companies to have any negotiating power with them at all. I mean, we're calling it a negotiation, but it doesn't really seem to be much anymore. In fact, drug companies seem to believe that they have to get their drug on the formulary with all 3 of the big PBMs in order to remain competitive, and the PBMs know that. Thus, the ridiculous rebate percentages, which drive the retail cost up and up, and thus your cost up and up. Get it yet? Feel free to break and consult the convoluted drug cost diagram once again, or just take a mental break if you need to. I would completely understand. But I'm going to keep going because it occurs to me that these rebates don't feel that different than a bribe. Webster's dictionary describes a bribe as money or favor given or promised in order to influence the judgment or conduct of a person in a position of trust. Quote. Isn't this that? Drug companies are giving money to PBMs in the form of a rebate for a preferred position on the formulary. And as I've been researching this topic the last couple of weeks, I've been really fighting against the assumption that there's a bad guy here. I mean, I guess I kind of naively want to think that we're all in this to help people and promote health and prolong life, but I got to be honest, I'm having a hard time seeing any good coming from PBMs. Sure, they help electronically deal with claims, but couldn't the health insurance companies just create divisions within their own companies to deal with that? Like, you'd think they'd want to, as PBMs are taking a piece of that money pie out of the hands of the health insurance companies that they're working for. PBMs also have Congress by the balls in a way, as they are some of the biggest lobbyists in Washington and have a ton of sway. Though, you may have heard on the news recently that our pal Bernie Sanders has been making a stink about the cost of Ozempic recently. A couple weeks ago, Sanders publicly released his letter to the CEO of Novo Nordisk, Lars Jorgensen. Remember, that's Ozempic's maker, and I linked to it in the show notes. It's a 5-page long letter with a list of references that would make a college professor proud, that ends with Sanders asking brutally straightforward questions of Jorgensen, as only he can, about why the cost of the drug is so high. He asks him also to provide financials on everything, including what the top 10 insurance companies and top PBMs are paying for it, and asks him to hand over all communications related to the drug's development and cost. Jorgensen has until May 9th to respond, so keep your ears out for how this plays out. The fact that Sanders asked about what each player on the chessboard of the convoluted diagram of drug costs is paying at least shows that he's onto the insane flow of money that we just discussed. But all that aside, I have to say that drug companies do seem caught between a rock and a hard place because of the PBMs. If you think about it, they're the only player in the pharma world that actually takes risks to create and make things better. They spend decades and billions of dollars to develop new drugs to help people. For Ozempic, for example, the work to develop that drug began almost 30 years ago, and they have spent reportedly about $10 billion to do it. Looking at Novo Nordisk specifically, they're actually owned by a not-for-profit foundation, which is pretty unusual for a drug maker. And interestingly, it's the largest charitable foundation in the world, with an endowment almost twice the size of the Bill and Melinda Gates Foundation. Their executives and board members are not paid with stock options like most other drug companies, but rather are required to buy and hold stock themselves, like you or me. This avoids them feeling pressure to make short-term decisions that would affect a bigger stock bonus. Don't get me wrong, I'm sure they're making quite a bit off the stock that they do own, but the unfortunate reality is that we're no longer in the 1920s where it's considered unethical to make money off of healthcare. It is firmly a business enterprise, so I can't fault drug companies for making money off of what they're producing. Though, famously, Novo's CEO, Lars Jorgensen, again, in 2015 said that curing diabetes once and for all is the goal. He said, quote, "I tell my employees, if we wind up curing diabetes and it destroys a big part of our business, we can be proud and you can get a job anywhere. We'll have worked on the greatest social service of any pharmaceutical company, and that would be a phenomenal thing," end quote. I gotta say, I kind of believe him. And it's hard to think that they're the bad guy, or at least the most bad guy in any of this. Stay tuned for part 2 next week. I'm going to go more into depth about what you can do to manage your drug costs, whether you're uninsured, privately insured, or on Medicare or Medicaid. And I'll talk a bit about industry disruptors like GoodRx, Mark Cuban's newish drug supply company Cost Plus, and others. Thanks for listening today. To catch up on more episodes and to get new ones delivered directly to you, subscribe wherever you find your podcasts: Apple, Google, Spotify, iHeartRadio, and more. If you'd like to be a guest or have an idea for an episode, let me know at www.drpatientpodcast.com. That's drpatientpodcast.com. Here's the disclaimer. Even though I am a doctor, I'm not your doctor. These stories, my comments, and all discussion is purely reflection about what's working in the healthcare system and what isn't. Don't use any medical information that you hear in these episodes to diagnose or treat yourself. If you have a question about your health, get in touch with your doctor or local health clinic.